Everyone. Welcome back to our webinars for today. I'd like to introduce Dr. Amanda Steiman, who is a clinician in quality and innovation at Mount Sinai Hospital and University Health Network. She received her MD from Western University and completed internal medicine and rheumatology training at the University of Toronto. She was granted the Jeff Carr Fellowship in 2011 and pursued her master's training through the Institute of Medical Science and further training in quality improvement and patient safety. Currently, her clinical focus is in lupus, and she runs the young adult SLE clinic at Mount Sinai Hospital with pediatric rheumatologist Dr. Earl Silverman to support young lupus patients through this formative period. Dr. Steiman, I'm going to hand it over to you.
Thank you so much, June. Thank you so much for the lovely introduction and for the opportunity to be here. Lupus Ontario is very near and dear to my heart. And my clinical focus, of course, is lupus. It extends far beyond a clinical focus. It really is a passion. And so it's wonderful to see this group again. Though I can't see many of you right now. I know you're there. That said, the topic that I'm going to present on is really not so much lupus focused as resource focused. And so I'm just going to take a moment to share my screen and we will get started. So my presentation is called Building Capacity for Capacity. And I'll share a little bit more why. So here are my disclosures. Really no potential for conflicts of interest within this presentation. And so I hope by the end of this presentation, you'll all be able to understand the goals of Project ECHO Rheumatology, understand next steps in integrating ECHO Rheumatology to increase capacity to care for patients with rheumatic diseases, including lupus, to understand the goals of the ACPAC program, so a second program, and next steps in its integration to increase capacity for patients with rheumatic diseases again. So I'm going to provide a little bit of context of which I trust you are all aware and perhaps have experienced to greater or lesser extents in your own lives, either yourselves or through loved ones. But we know that arthritis and musculoskeletal disorders are among the most common chronic health conditions in Canada. And the national prevalence is 6 million people. So 16% of the population is afflicted in some way. It's the leading cause of morbidity, of disability, and of healthcare utilization in patients at all stages of life. So this is an important, significant issue. And there was an Arthritis Alliance of Canada report just over 10 years ago that revealed that the number of patients with rheumatoid arthritis in Canada has doubled from 1990 to 2005, and then was expected to double again from about 272,000 in 2010 to over 500,000 by 2014, which would reflect 1.3% of the population. And of course, from a lupus context, we know that lupus is not as common a disorder, but we do know that prevalence rates typically increase in lockstep. There's certainly increased prevalence that's anticipated in the context of lupus as well. Now, couple that with Canadian Rheumatology Association's recommendation that all patients with inflammatory arthritis be managed by trained and experienced healthcare providers. And I put a little asterisk there because I think it's all the more important in the context of lupus, wherein multisystemic organ involvement is really the rule, and where those very specific and oftentimes subspecialized expertise are all the more critical. And so the mantra that is shared among rheumatologists and in the musculoskeletal disease community is that time is joint, which means that the sooner the inflammatory condition is detected, the sooner it can be treated, it can be managed, and that has all sorts of positive ripples downstream. So both from the perspective of local articular problems, so decreased damage at a joint level, but also we know systemically, we know that inflammation begets systemic challenge, from the perspective of cardiovascular risk, systemic risk associated with chronic grumbling inflammation. And so not only is time joint, time is also the other organ systems impacted by any form of inflammatory disease. Now, on the background of this, the number of rheumatologists in Ontario has not meaningfully changed over the past 20 years, although the number of patients who need to see rheumatologists has increased and continues to. And why I say it has not meaningfully changed is, while the number from 20 years ago was 160 rheumatologists, and if you look at the roster of rheumatologists in Ontario today, there are numerically more than 160 who are practicing. The reality is that, between part-time practice or physicians who are working in both internal medicine and rheumatology and so on, there are numerous factors that really mean that there's probably approximately equivalence over the past 20 years in the number of rheumatologists practicing in rheumatology by way of hours and so on. Now, as is always the case, disparity in care delivery is amplified in rural and remote areas. And so in the downtown core of Toronto, it would be hard to imagine that there would be, tremendous dearth of rheumatologists across the province, but Ontario is a big place, and patients come from far and wide, and the disparities are certainly amplified as we get further from large cities. And so it's as if we are pushing a very large boulder up a steep hill. So patients are increasing, rheumatology care is remaining consistent anyways over decades. So this is a big problem. So even prior to seeing a rheumatologist, however, there are very significant bottlenecks, and these actually reflect the lengthiest delays, and they're meaningful from the perspective of disease management. So if we start here at the left with the patient, from the time they experience the first articular symptom in this case, so these data are for articular symptoms anyways, there's 172 days before they actually present to primary care talking about this issue. So that's approximately 6 months. So patients will weather this. They'll say, oh, it went away. Oh, I hurt myself doing something. And so the gravity, the severity, and the chronicity of this is not always apparent up front. Then, once they've seen their primary care provider, their nurse practitioner, their family doctor, there's a further 115 days, so another several months before a rheumatology referral is made. And so there's a bottleneck there as well. And so in part, it's on the basis of perhaps primary care doctors performing some of the workup themselves, and quite appropriately so. For other, in other cases, it's that there is delay in appreciation of inflammatory over mechanical types of joint pains, or some combination, or perhaps reluctance on the part of the patient. So multifactorial, certainly, but at the end of the day, that reflects 10 months of opportunity that we could really be reflecting on from the perspective of optimizing disease management. So that's an important piece of the puzzle. But now I hope that I'm an optimist. I hope that the glass is half full rather than half empty. And I like to see this as an opportunity. So right now, the problem as it's laid out is that we lack adequate resources to provide optimal care. In rheumatology, we have a math problem, but we also have resources that perhaps we could leverage better. So can we leverage what resources already exist to improve the quality of care we deliver? If we were to look at this as a rheumatologist problem, we would likely need about 10 times the number of rheumatologists that we have in order to adequately service the population. It's not happening anytime soon, probably not ever. The funding, the structure of our healthcare system really does not permit for that sort of increase in numbers. And so we have to work smarter, not harder, in many cases. And so I'd like to share with you 2 projects which are really at the core of trying to leverage what already exists. So provincially, there's Project ECHO Rheumatology, and nationally and beyond, where we're struggling with much of the same issues. There's the Advanced Clinician Practitioner in Arthritis Care Program. And by way of relevant disclosure, although not a classic disclosure, I chair Project ECHO Rheumatology, and I'm the medical co-director of the Advanced Clinician Practitioner Arthritis Care Program since 2020. And so that's the context in which I present today. So by way of Project ECHO Rheumatology, so there's a burgeoning need for rheumatologic care. So full stop, we've talked about that, and I hope that I presented compelling evidence for this. So Jessica Whitfield, who is an Ontario-based rheumatology health services researcher, quite prolific. So she published in 2016 that wait time benchmarks for inflammatory disease are not being achieved. And further, that osteoarthritis and systemic inflammatory rheumatic diseases were the main reasons for referral to a rheumatologist. And for systemic inflammatory rheumatic diseases, most delays occurred prior to referrals to the rheumatologist, which I've just presented. So then I ask you, is it that we have a shortage of rheumatologists? We do. There's not enough of us to go around, and we're a nice bunch. But really, is it that, or is it that we have a shortage of rheumatologic acumen? So in other words, do rheumatologists need to be the only ones at the helm managing the care of rheumatology patients, given the math problem that I've just shared that we have? So I don't think that the distinction is trivial here. So could we work better or smarter by leveraging the resources that already exist? And so I present to you the very same slide that I just did a couple moments back. And I wonder whether Project ECHO may be in part a solution, and I'm hopeful that it has been thus far. So what is Project ECHO? So some of you may have heard, and I can't see you, so I can't ask about a show of hands, but I'll share a little bit more about this. So Project ECHO, so it stands for the Extension for Community Healthcare Outcomes. There was a model developed to increase access to care for underserviced populations. It was started by Sanjeev Arora, who's a hepatologist based out of Albuquerque, New Mexico in 2003. So the context was that there was a common chronic and complex disease that was managed in primary care, or could be managed at least in part in primary care. And so his context specifically was hepatitis C, which was endemic through New Mexico, and only 2 hepatologists through the city, through the state rather, to manage it. And so he founded Project ECHO. So the ECHO Act in 2016 was actually enacted by the Department of Health and Human Services, and that was because they found that the uptake of this program was so important that there would be reporting on any such further initiatives going forward across the United States. So what is Project ECHO? So I want to just play for you a 1-minute clip, which will allow some context before we talk a little bit more. I'm hoping that the YouTube ads don't come in advance. So let's see how this works. There we go.
Project. Think of it as speed internet connection for the healthcare system. It spreads new medical knowledge.
We're not able to see the video.
From University Medical Center.
Sorry, you're not seeing the video.
No, we can hear it, but we can't see the video.
You know what? Okay, let me do this. Here, I'm going to share this now. Let's see if this works.
We can see the screen now. Yeah.
Perfect.
Other specialty care sites, the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under ECHO, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. ECHO exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project ECHO, changing the world fast.
Now I'm going to stop that share I'm going to go back to my presentation, and I think we're back up and running.
Yep, I can see your screen.
That's great, thank you. So then in short, the ECHO model uses technology to leverage scarce resources by way of sharing best practices and reducing disparities across a large geographic region. And so in our case, Ontario. So it's an Ontario-based initiative. And it does so by applying case-based learning to manage complexity. And so rheumatology is right for that. It is exactly the kind of specialty that really benefits from this type of model. And then all the while we evaluate and monitor outcomes. And so, we were Zooming before Zooming was a thing. So I remember going to Albuquerque back in 2015 and 2016 to do the training before we launched our ECHO. And they talked about this platform called Zoom that very few people had heard of. And it's quite fascinating to see how the world has changed. And so what we offer is a weekly interactive video conference session that connects primary care providers from truly all across the province to a rheumatology hub. So around the table at our hub, we have rheumatologists, we have family doctors with a special interest in rheumatology and rheumatic diseases. We have a physiotherapist and an ACPAC trained physiotherapist at this point, as well as a pharmacist and a nurse. And the sessions include a didactic presentation by one of us or by special guests about a topic, about a disease process, about approaches to management, expanding differential diagnosis, about management, treatment, monitoring, and so on. And then one of the primary care providers from across the province will present a case. And it's an anonymized case. So this is not like an e-consult where you get advice about a specific patient, but rather they present an anonymized case, and that's used as a learning tool for all. And so once they present, all of our community partners go through rounds of clarifying questions, and then we work towards narrowing the differential diagnosis if there's a question of what the diagnosis is, or if the diagnosis is clear, then there will be discussion surrounding management or next steps in workup and so on. So you see around the table here, so this was actually pre-COVID. And since COVID, we've been doing it all virtually. So we only have a virtual hub. But Claire Bombardier and I had co-chaired this for quite some time. You see us up at the top left over there. And around the table, we had Ashley, who is our admin assistant, Laura Passeland, who's an ACPAC provider, so a physiotherapist with an extended role, as well as Anne Samet, who some of you may know from the Toronto Western Lupus Clinic. So she was a lupus nurse there for many, many years and has since retired. And so really what's beautiful about Project ECHO is that it's an all teach, all learn philosophy. So as much as we have an expert hub, we all learn from each other, so the family doctors talk about their practice and their best practices surrounding certain aspects of care that are germane, but maybe not directly rheumatology focused. And we all share our expertise that way. And so it really feels like a family room kind of conversation. We build a community of practice, and it's lovely to get a phone call from somebody in Manitoulin saying, hey, I wondered if I could run something by you. And so it really breeds access and collaborative care just by virtue of how we run things. And we also hold an annual boot camp, which was on a hiatus through COVID, but we're actually resuming next month for the first time in several years, where we do hands-on techniques, joint exam, skin exam, germane to rheumatology, injection techniques, and so on. So we're expecting about 50 people to be coming into Toronto later in November. So our community partners are mainly physicians and nurse practitioners, but there is a smattering of registered nurses, physical therapists, other medical professionals like chiropractors, occupational therapists, and pharmacists. And so I've mentioned there's a didactic, usually it's about 30 minutes long. It really focuses on a pragmatic approach with issues germane to primary care providers, and tailored to the results of serial need assessment. So really this has been born of a quality improvement framework where we take iterative approaches on the basis of the feedback provided. And so it really has evolved and morphed over its 7 years that we've been doing this. And there are presentations by Core Hub members and by visiting experts. And so over here is one of our family docs who's up in Massey, Ontario. And he's discussing some of the intricacies of a case. So I'll just give you a flavor for the next few seconds and let me know if this is okay and if you're able to hear him well.
Anyway, that was one observation. Otherwise,
Working.
his hands, he's got marked ulnar deviation of the MCP joints, right? At the MCP joints. So it'd be really interesting to know if his x-rays of the hand showed any erosions and what the radiologist said about them.
I didn't do them recently because he wasn't actually complaining of any hand symptoms. It was just the wrist. The last hand x-ray was done in 2013. And it commented on marked osteoarthritis of the wrist, just of the wrist, marked OA of the DIP joints and PIP joints of the fingers, and also at the base of the first metacarpal.
But they didn't even mention the
No.
NCPs
No.
when there's marked ulnar deviation in both hands, just like that picture that was shown during the didactic.
But on the left hand, the MP joints are relatively well preserved.
And so you can see that there's this very lively discourse. And these were two family doctors who had come in really hoping to expand their rheumatology knowledge. And they actually gained such a tremendous facility with a lot of the rheumatic disease topics. And Alan particularly, he's a lifer. He's been starting biologics. He's been really managing because there are no rheumatologists for hundreds of kilometers around him. And so he has become the de facto champion locally. And so other family doctors speak to him and rely on him as a resource when it comes to managing and, working up rheumatic diseases. So to date, we've had 465 primary care providers go through since its inception. And of these participants, 114 have presented one or more rheumatology cases. Others have just sat and soaked and listened. Some people prefer not to present, or they don't have patients of their own that they can present. And so there have been well over 200 patient cases presented with follow-up recommendations provided by the hub for each case. So after each session, we write up a list of recommendations for the primary care docs then to take back to their specific patients. We have touched all limbs across the province. So we've gone as far north and as far east and as far west. So really we have people coming from all over the province. There's been a significant increase in primary care provider self-efficacy and knowledge surrounding rheumatic diseases and their management. And really what's always been a challenge for us is because there are presentations on topics as diverse as lupus and connective tissue disease and vasculitis and rheumatoid arthritis and psoriatic arthritis, it's been hard to sort of capture whether or not there's been an increase in prescribing of a certain medication because we never know what comes through the door, which is kind of unique compared to something like a hepatitis C echo, where there are only certain medications that are going to be prescribed in excess on the basis of the learning. And so we have been working through some mixed modeling and so on to really be able to show what qualitatively and on the basis of these surveys that we've done for so long is quite clear. In addition to our Ontario focus, we've had 13 out of province participants, both from across Canada, as far as Nunavut, as well as internationally. And so we've had doctors who have come recently from the Ukraine, from Africa, and from the US and India to join our sessions. And so while that's not the mandate of this Ministry of Health funded initiative, it's certainly wonderful to see how it's such a small rheumatology world globally. So to date, we've done 230 such sessions. They're 1.5 to 2 hour sessions, and we've been able to award nearly 8,000 hours of continuing medical education. So this has been, we hope that it has had ripples. And so when you look at the ECHO outcomes, just for instance, when you look at this Likert scale of the participants who rate themselves to start from either no skill at all to feeling like they're experts, we've seen that there's been very significant increase in their confidence in their ability to diagnose a patient with inflammatory arthritis, to identify a patient who's having a flare of their rheumatologic disease, and to determine which patients are appropriate for referral to rheumatologists. And so I'll mention that this is a really interesting point because you wonder whether or not you can measure success of a program on the basis of whether or not there are fewer referrals coming in or more referrals coming in. And one could see where either would be the case. So with increased recognition of inflammatory conditions, there may be actually an increase in referrals to rheumatologists on the one hand. On the other, you may consider success if some of the things that they would have previously referred, perhaps less appropriately, to a rheumatologist are now being redirected or managed themselves. Then it's very difficult to determine whether or not increased or decreased rates of referral actually reflect success. And here are some testimonials. So this is one of the doctors from Northern Ontario. I think it's a wonderful program because for us, the access to specialists is very hard, and it's the waiting time. When you have some questions that you just want to get answers quickly. And I know that we can use some of the resources like eConsult and stuff. And I'm really excited and thankful because it's really helpful. Another said that I like getting the input from the others and hearing their cases too, because it sort of runs my perspective, like the case of dermatomyositis that someone presented. Dermatomyositis, never seen a case like that before. And it's also good to get other people's ideas on how they would treat things, like discussions about who would use steroids and who wouldn't, and what's available to different parts of the province. That's all very interesting to me. So we see that they're having exposure to disorders that they otherwise wouldn't, and lower frequency, lower prevalence disorders such as dermatomyositis and of course lupus are things that we discuss regularly. And so that awareness, that the initial workup, the importance of getting the ANA or the ENA or the anti-double-stranded DNA, and always getting a urinalysis to make sure that there's no inflammation in the kidney and so on, is something that we've been able to share and that has had really excellent uptake. And so another testimonial, and it's the last one that I'll share, is that the beauty of the ECHO thing compared to reading UpToDate is perspective. So UpToDate is sort of like an online resource for docs to use, and it's an encyclopedia geared to physicians where you can look things up surrounding cases and so on. So this doctor says, I can read UpToDate all day long, and I'll never get the perspective that I got last week from Laura about spondyloarthropathies. You need to really read UpToDate and really see patients and learn before you'd ever cure a patient. And so here we have this opportunity to really all teach, all learn, and to grow exponentially from discussion around a case. And so it's been a really gratifying program. And so we hope that with Project ECHO in action, it's increased awareness of signs and symptoms of systemic autoimmune rheumatic diseases. It's allowed for co-management of systemic rheumatic diseases and awareness about features of disease flare, of medication monitoring. And we do see this among those who have been participating, that they have been seeking out the rheumatologist that they do send their patients to when they've noted that the disease has been flaring for patients. They've been able to be active collaborators in medication monitoring, and all of these things builds capacity in the system. And so that's been critical. There's also been increased facility with early management of systemic autoimmune rheumatic diseases, including disease-modifying anti-rheumatic drug initiation. So just the other week, we had one of the cases presented was a patient who appeared to have an early diagnosis of lupus. They had rightfully made a referral to a rheumatologist, and they will be initiating hydroxychloroquine in the interim. And we know that all of the medications that we use take time to take effect. And so the hydroxychloroquine was a very appropriate medication to start and to get going even as they await that referral. And so, it's wonderful to see these things in action, and pragmatically so that patients can have the best possible outcomes. So in summary, Project ECHO is really meant to build capacity, to create local champions in primary care. They may be the only game in town for hundreds and hundreds and hundreds of kilometers, and to build a community of practice across the province. And so I'm happy to be sharing our results thus far with you. And I'll switch gears a little bit to the ACPAC program. And this stands alone, but what I'd like to encourage you to do as I share a little bit about the ACPAC program is to see how there are synergies between the two. And to think about how this impacts you as a patient or a loved one of a patient. And so ACPAC, which stands for Advanced Clinician Practitioner in Arthritis Care, is a hybrid academic and clinical training program that prepares select and experienced physical therapists, occupational therapists, nurses, and chiropractors for extended practice roles in the diagnosis and management of patients with arthritis and musculoskeletal conditions. It focuses on assessment, diagnosis, triage, and independent management of select musculoskeletal and arthritic disorders. These are all adult learners. They all have extensive clinical experience in allied health fields. And it's a competency-based interprofessional program that is delivered a combination of virtually and in person in Toronto. And then preceptorships happen wherever is local to the participant. So it's a 10-month program. There are 5 weeks of intensive didactic programs, as well as many hours of asynchronous learning modules. And so we just had our first week this past week of our new cohort of 13 highly skilled, highly motivated physiotherapists, occupational therapists. There's one chiropractor and there's one nurse in the cohort from all across the province and one from Ireland. There are 160 hours of clinical preceptorships in rheumatology and orthopedics, as well as specialty clinics where they go in, they see patients, they function as a resident or a fellow, essentially. And then because of the context in which this program has been built, and was built 20 years ago by Rachel Schupak and Katie London, who are rheumatologists and PhD physiotherapists respectively, who really carried this program for many, many, many years, and who passed the baton in 2020. They think about how this additional training is going to fit into their local context and how they're going to take it back and use it to better support the care for patients with rheumatic diseases across the province and beyond. They're trained in comprehensive assessment, including lab and imaging interpretation, clinical documentation, and disease management. And right now we have over 70 faculty in rheumatology, in orthopedics, in radiology, in pharmacology, who are teaching these trainees about the various aspects of the jobs that they do. We've had 115 graduates to date working across Canada and a few internationally. Of the ACPAC program has been born several models of care. The most common among these is really the extended role provider or the ACPAC practitioner based in a rheumatology clinic. So they'll work alongside the rheumatologist in a role of triage, in seeing patients, in trying to really improve capacity at the level of rheumatology. Similar models exist in pediatric rheumatology, and truly they were one of the originators right at the start of the program. And so pediatric rheumatology has a long history with ACPAC, where it's been tremendously successful. There are also hub and spoke collaborations with remote rheumatologists managing patients virtually, with the ACPAC really being the person with the boots on the ground, doing the physical exam, doing the joint exam. And this has been after training with that rheumatologist. So there's really a rheumatology ACPAC dyad, and they work together to ensure that their joint exams, their physical exams, their histories line up well, and there's good fidelity. And then the rheumatologist can see these patients who are thousands of kilometers away locally. And so this is sort of a hybrid telerheumatology model of care. And then more recently, there's been a push towards an extended role provider based in a community health center, other primary care setting, which is fascinating and exciting. And I think this is where we may have some real opportunities for collaboration with Project ECHO as well. And so in practice, this is a study that was done back in 2019 by Vandana Aluwalia, who's a rheumatologist in the community based out of Brampton, as well as the team then. And they looked at these ACPAC providers, and they found that the ACPAC ERP model was equivalent to solo rheumatology with respect to patient experience and satisfaction. So they pulled the patients who were seen by the ACPAC ERP, and that collaboration with an ACPAC ERP can increase capacity in a community rheumatology clinic on the basis of the volumes of patients seen. So they were able to see more patients and see more patients with a positive experience and with good success and fidelity under those circumstances. And then I'll share something that we've recently presented at the Canadian Rheumatology Association meeting, was describing that telerheumatology shared care model. And so this was a hub and spoke model where a single rheumatologist, and this was Dr. Rachel Shupak, based out of St. Mike's, and an ACPAC ERP who was based in Espanola, so hundreds of kilometers away. They established a collaborative monthly telerheumatology clinic to care for suspected inflammatory arthritis and connective tissue disease patients. And then we had a retrospective analysis of this. And so this was one ACPAC ERP who would then work in a similar capacity with multiple rheumatologists. And they served a population of 565,000 people, among whom there would be many patients, and spanned an area of over 400,000 square kilometers in the Northeast Lynn. And so of the 504 total visits that were performed over the span of 9 years, involving 124 unique patients, only 8 needed to be seen in person in Toronto for follow-up, which means that the other 98.4% were conducted exclusively via shared care and telerheumatology. And patients with suspected inflammatory arthritis were seen by the rheumatologist virtually on average 79 days after ACPAC initial assessment, at which point they already had their labs, their x-rays, their workup in hand. And so, with the model, you can see that if we had multiple rheumatologists working in a similar capacity with a single ACPAC, it can dramatically amplify access to care, especially in these rural and remote areas, because we have the one ACPAC who can travel to various communities and connect with the rheumatologist at the hub. And so it worked very well. We've just submitted this for publication, actually. So what was fascinating was that this is tremendously cost effective. So calculations of hypothetical distances between home postal code of these patients and St. Michael's Hospital was calculated. And over the 9-year study period, with clinics running only once a month, so this was a 1 day per month, 11 months per year venture, there were nearly 500,000 kilometers of travel saved. And so the carbon footprint there is excellent, not to mention the impact on patients in terms of disruption to them, to their drivers and family members, and to loss of work hours and so on. And this was with an estimated cost savings, and this was just direct on the basis of the Northern Ontario travel grants that patients collect, which was $276,000, which would be more than enough to cover this position if one were to shift the funds that were saved directly to fund this program. Of course, we understand that this is not always exactly the case, and so we've encountered challenges there. And so the challenges and pitfalls with respect to ACPAC have really been organizational buy-in. So you need to have people who champion this type of model high up, because funding's always been an issue. So this isn't a provincially funded role. So oftentimes the rheumatologists themselves, in the most common way that these ACPAC providers are employed, are paying them themselves, and feel it's worthwhile because of the increase in number of patients who can be seen safely with the ACPACs in their clinic. There also needs to be an enterprising spirit among those who are in the program. So it's if you build it, they will come. So there are no promises with respect to employment thereafter. So it really is a little bit of a leap of faith. So it's an exciting program. When I think about potential synergies, and bear with me, this is a busy slide, I'll just spend a minute on it, and I think this is really the last one, is that you have a patient who has an inflammatory rheumatic condition. They see their primary care provider. If they have a whiff of anything that is going on that sounds inflammatory or sounds rheumatologic, we have an ECHO trained primary care provider who can serve as that local champion for a whole group of primary care physicians and nurse practitioners. They will then have liaison with a local ACPAC therapist who can see them, who can perform that physical exam, who can, with good fidelity with rheumatologists on the basis of their training, know that if they see swollen joints or an inflammatory rash like a malar rash or a dermatomyositis rash, their index of suspicion is raised. They then send off the required investigations and connect directly with a rheumatologist, such that the patients who need to be seen most urgently are going to be put right up top to the top of triage and be able to have medication started quite rapidly. You know, the other offshoots are that after that assessment by the ECHO trained primary care provider or by the ACPAC, they can then be either fed back to their own primary care doctors with some guidance with respect to more chronic management of chronic osteoarthritis or suggestions for management otherwise or self-management. And so this could work quite nicely synergistically. And so we are trying to create some of these pilot projects to see if we can leverage both resources simultaneously and meaningfully. So in summary, Project ECHO Rheumatology and ACPAC extended role providers are both proven capacity builders for the delivery of rheumatologic care in Ontario and beyond. These tools are in our armamentarium for the delivery of high quality patient care for patients with rheumatic diseases. And so I hope to be able to share more updates, more synergies, and hope to be able to support providing the best possible care for patients with rheumatic diseases. So I thank you for your attention, and I'd be delighted to take some questions.
Thank you, Dr. Steiman. That was fascinating presentation. I don't know how many people had heard about ECHO and the ACPAC programs previously. So I think they're getting a better understanding now of the different models of care that are coming, you know, to life, I guess, within the province, simply because we don't have enough rheumatologists available. Let me take a look to see if I've got anything in the chat on questions. At the moment, I don't see anything. I've got one for you. I'm just wondering if you've been able to analyze how many days in savings there actually are once you've implemented the ECHO program. You'd mentioned there was originally a 115-day gap. So have you been able to analyze if there's been a reduction in that?
So what we are looking at as a first step is we're looking at referral quality, right? So that can sometimes serve as a surrogate, because when you're faced with as many referrals as we're faced with, triage becomes very important, and the quality of the referral coming in is important. And what we're looking to do is seeing whether or not ECHO has impacted the quality of referral on the basis of a standardized metric that's been published, to see whether or not the quality of referrals pre and post 10 to 15 or more sessions of ECHO has resulted in a referral that does more and that allows for better and more comprehensive triage. So I'm indirectly answering your question. You know, it's been very, very difficult to measure whether the 115 days on the basis of the providers that have participated and on the basis of the numerous different types of conditions that we're seeing is hard to measure. It's also hard to measure from the perspective of REB and ethics approval, because it requires the participation of so many community providers and goes through so many different potential local health area networks and so on. So because it strays from the university, the ethics behind getting approvals for going into people's charts can prove quite challenging. And so I'm probably oversharing a little bit, but it's been a logistic feat.
Yeah.
So we're hoping to tackle that indirectly. So it's a great question. And I hope to be able to share the results of this upcoming study with you.
Thank you. We do have a couple questions now coming in through the Q&A. With respect to the ECHO program, is there a way that patients can encourage their GPs or HCPs to take part in the program?
So that's such a great question, and I'm so glad you've asked it. So the answer is yes, absolutely. We had actually pursued a similar initiative by sharing a pamphlet with the Ontario Rheumatology Association, so that rheumatologists could encourage their GP colleagues to participate. You can tell them about it. You can share that you had heard about it. Have you heard about this program? Some have, some haven't. But there's an ECHO Ontario website they can go to. There's offerings beyond rheumatology as well. So there's chronic pain, there's mental health, there's palliative care, and so on and so forth. And it's tremendous because it's free and it provides free CME hours. And you know, a lot of doctors have really enjoyed this as a beautiful community of practice. So tell them about it.
Well, if it's free CME hours, I'm sure you should be able to get some people to sign on.
Yeah, conferences are so expensive these days. So
Yeah,
it's a great opportunity.
So how do you find out if your own GP participates in ECHO?
You can ask them.
That's
Ask them. So it's not posted, and the beauty of ECHO is that people come and go. So we have some lifers who started in 2016, 2017, and still come. You know, and the thing is that while the curriculum repeats itself, because there are new cases each and every week, it's never the same. And because we've been adapting curriculum to meet the needs of our participants, we started with a curriculum of about 25 sessions, and we've expanded now to 45 sessions. So we have a year-long curriculum that repeats itself, but it's nice to hear again because through different lenses and with the participation, it's always a different session. So there's never a posted list of static doctors who are there. They come, they go, they stay for, you know, half a year, then they come back 2 years later, or they present a case. So it's always a resource that we never close the door for them. So just ask.
Okay. And when it comes to ACPACs, are these practitioners mostly found in rural settings to help facilitate access to care?
Wonderful question. These questions, they could have been planned to, they weren't, but they could have been. So the answer is no. I mean, anybody who wants to can register for ACPAC and apply. And it was a competitive year this year. So we unfortunately had to turn a few people away just so that we could provide the support and the preceptorships and so on that are required. But there's been a pilot through the Ontario Rheumatology Association with the Ministry of Health to fund local ACPAC. So in this case, there's one who's come from Thunder Bay, and there's another that's joining this coming year, who's also coming from a rural and remote area, who will be going back to practice. And June, I don't know if you wanted to share a little bit about the Lupus Ontario-based initiative to help support one of the ACPACs in Thunder Bay, because that's been wonderful as well.
Yeah, thank you. Well, that's just been one of our walk participations has been basically to fund, the goal has been to fund an ACPAC out of Thunder Bay. And so the monies raised on that walk is being directed to fund an ACPAC for next year's enrollment program. So we're hoping that that becomes something that you know, is other communities will take on in the north, and this was driven by the community up north. And that was what's so great about it, that when you have a community who wants to get involved in you know, increasing care, then you're able to raise the funds to get additional monies that unfortunately the province doesn't seem to be able to provide.
So these pilots are going to be critical in terms of funding the training. You know, and we know from other programs that people are more likely to return home as opposed to move away to fill a need elsewhere. So, you know, we are delighted that this year's cohort has trainees from far and wide across the province, with the hope that they will return home and be able to provide that additional level of care there. And that's the goal.
That's great. I think we've come to the end of our questions. So I want to thank you very much for presenting the ECHO and the ACPAC programs to everyone. We can see how passionate you are about building capacity through education and the different models of care within the province. So we really appreciate it. And we're so happy to have you at Mount Sinai and in Ontario practicing and coming up with these, you know, new ideas that will help improve everyone's access to care. Thank you very much.
Thank you so much. Thank you all for your attention, your great questions, and for the opportunity, June.
Thank you.
Thanks. Take care.
Take care. Bye-bye.